to this month's Teach Educational Rounds. Here with us today, we have Marilyn White-Campbell, who will be presenting on geriatric considerations for supporting smoking cessation with older adults. So we're going to get started with KMH's land acknowledgement. KMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of KMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they are known at the time. Today, Toronto is covered by the Toronto Purchase Treaty No. 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. KMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our care and practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. Now, I encourage everyone to introduce yourself in the chat and let us know which traditional territory you're joining us from today. If you're not sure, I'll put the link in the chat where you can find that out, so give me a moment. While you're doing that, I'll share a little bit about myself. So like KMH, I'm currently located on the lands of the Mississaugas of the Credit. I'm a third-generation Canadian. I grew up in the GTA and then last year moved to the west end of Toronto, where I've truly grown to appreciate the community and the vibrancy this land has to offer. I acknowledge the privilege I have as a white settler to live here, and particularly as someone with type 1 diabetes, I am grateful to have access to insulin and all my other required medical supplies. I myself am committed to reconciliation. I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard and reflected within my work and personal life. So thank you. Thank you, Lori, for sharing. That's awesome. I am going to continue on with some other housekeeping items, but please do keep sharing in the chat. We do like to hear everyone's thoughts. And all right, so if you're interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you registered for the webinar and completed the pre-learning assessment. As well, make sure you signed into the webinar using your full first name and last name so we can track your participation. And lastly, make sure to complete the evaluation and post-learning assessment. That will be emailed to you by tomorrow, and you'll have 1 week to complete that. Along with that, you will also be receiving a copy of the slides as well as the recording if you would like to review or share with any colleagues. So here's a little bit more information on our presenter today. Marilyn White-Campbell is a clinical geriatric addiction specialist with Baycrest Long-Term Care Behavioral Support Outreach Teams. She has over 35 years of clinical experience working with older adults with substance use disorders and has been the recipient of the Ontario Psychogeriatric Award of Excellence and the inaugural Seniors Mental Health Outstanding Care and Integrative Practice Award. So it is an honor to have her here with us today, and welcome, Marilyn. And just a note about her disclosures, just that she had received some NRT from us to use in long-term care homes in her area. And please note that the content of Teach Educational Rounds is centered on evidence-based guidelines from the following sources. Nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So please feel welcome to use the chat feature throughout the webinar to post any comments or answer any prompts from the presenter. To do this, you can click on the speech bubble icon in the control panel at the bottom. Please just ensure you select everyone so that all panelists, hosts, and attendees can read and respond to your comments. As well, just a note that there will be a dedicated question and answer period at the end. So if any content-related questions come up, feel free to hold on to those until the end, and Marilyn will be able to answer those for you. So with that, I will leave it to Marilyn to take it away. Thank you, everyone, and enjoy the webinar.
Thank you, Natalie, and thank you, CAMH, for inviting me to come and talk to you today about geriatric considerations for smoking cessation with older adults. Just going to put my Okay, so we want to look today on some of the best practices in care of older adults with dementia in the context of nicotine dependence, because that's a very special subpopulation, and look at some of the ethical principles and practice tips to support smoking cessation um, in residents of long-term care, including safety to smoke. And I'm going to be using some case-based learning to look at some of the different approaches. We've learned a lot over the past few years during COVID on working with the long-term care homes on smoking cessation in this vulnerable population. So we know that smoking in the older age group is prevalent. It does drop off with older age, but if you think about it, if you look at the substance use attributable inpatient hospital per capita costs in Canada, it is the age group of 65 plus that is the most costly. So many people actually stop smoking in later life due to health reasons and end up in care, or they die from smoking related illnesses. So it is a population to keep on your radar. And the one thing that I want to bring to the session today is to take into consideration that in this group, that fires and fatalities around smoking is a really, really huge concern. So there are some clinical some research on smoking in long-term care in the United States. We haven't seen a lot of it in Canada, but we do know that there are, I was able to get some data from Cessation for the Canadian Centre on Substance Abuse to look at the number of fires. If you look in this population here, we have people in long-term care homes age 55 and up. But if you look at this age group here, 55 all the way up to 75 years, we have a combination of fires and deaths as a result of fires in the older adult population. So it's very, very concerning. And if you look, even take a deeper dive into it, it's in the older adult population 65 to 75 years old that when there is a hospitalization due to a smoking or a tobacco related fire, that it's the most costly. So the older smokers are usually heavier smokers. They've got 30, 40 years of smoking, and so they have higher levels of nicotine dependence. And the one thing that's different in this population is that if there is cognitive impairment, it can make the quit challenging. So we know that smoking is associated with all three major causes of death among elderly, including heart disease, cancer, and stroke. And the risk of dying from a heart attack is 60% higher for smokers than non-smokers who are 65 or older. And people who are smokers are 2 times as likely as non-smokers to develop Alzheimer's disease and dementia of any kind. So it is a preventable, actually. Smoking cessation can be a preventative, looking at prevention of dementia. But why do we care about this this population of older adults that are smokers and that have dementia? How do we support those individuals, their needs, with consideration to their dependents and the cognitive issues, and maintain the safety of the population? Because it's not just the individual that we're concerned about, it's the general population in a long-term care setting or in a supportive housing setting. How do we provide some ethical and compassionate care when the individual makes risky decisions? So here we have Mr. C. This is a gentleman who we brought to the attention of Nicotine Dependence Clinic a number of years ago, probably 6 or 7 years ago. And this is a gentleman who was a very, very heavy smoker, and every day he would go to the nursing station and they would give him a couple of cigarettes. And when he started to to decompensate, the family bought an e-cigarette, and he lit the e-cigarette with his lighter. So he was deemed no longer safe to smoke, and so the home was interested in supporting smoking cessation. But the family said, no, we don't want to use the patch. He had the patch when he was in hospital, and now, he's continued to go outside to smoke, so it didn't work. So we don't want to waste our money on the patch. So, but what was happening is he became very agitated. He asked to go out for a cigarette. So we asked the family to invest in using the nicotine spray. And so when Mr. C would come to the nursing station, they would say, Mr. C, please sit down just 1 minute. I'm going to get your cigarettes for you, but first I want you to take some medication. And so they would turn around, get the nicotine spray out, spray it in his mouth, and say, just hang on a second, Mr. C. I'm going to go get your cigarettes and your lighter. And literally, they would take enough time to write down that he'd been given the nicotine spray. They document that on the Mars sheet. They would turn around and Mr. C was gone. So what does that tell us? It tells us that the nicotine, his nicotine needs were met, and he literally forgot that he was asking for a cigarette. So it satisfied the need for his smoking, and so all those behaviors, the pushing and arguing with nursing staff, that behavior was completely gone. So we realized that this is something that was really important to consider when working with older adults with dementia. But during the pandemic, there were a number of ethical challenges. There was a sudden paradigm shift from individual rights, sort of the principles of autonomy, client-centeredness, to principles of utilitarianism. So what were the best outcomes for the greatest good and the greatest number of persons? So is one person's right to smoke, does that trump the rights of the individuals in the long-term care home? So we wanted to make sure that we struck a compassionate balance between maximizing the benefits of both the individual and the collective safety of the home and minimizing the harm. So and of the individuals and collective risk of restrictions to liberty. Because when you think about it, when at the height of the pandemic, if you had a resident who was a smoker who was going in and out and they had COVID, they were touching their mouth and the cigarettes and leaving cigarette butts behind, and other residents were picking it up and they were touching the elevator buttons to get in. So it was something that was very, very concerning. So, but we recognize that we couldn't just leave individuals in their rooms without some supports. So we see in this comic, what happens when people don't have their cigarettes. So we had a lot of people that ended up in isolation that were really, really highly nicotine dependent, and we needed to support them. And so that's where, CAMH came to the rescue, and I thank them very sincerely for their support. So we were in a crisis situation. There was some reactive stance to decision making, and COVID was very novel, and it was a very steep learning curve. Every time you looked at the best evidence, what was the protocol at 9 o'clock wasn't the same at 10 o'clock. So there was also decreased staff, lack of PPE. There were visitor restrictions, and residents and resident person isolation when people were COVID positive. So are we in the same situation now? No, things have changed. The vaccines seem to be working, and older adults in long-term care seem to be faring much better than at the beginning of the pandemic. But certainly having access to nicotine replacement during that time was really, really critical. So the vaccines have really changed the landscape. So we know that in terms of the ethical challenges, it breeds vulnerability, helplessness, hopelessness, and depression, PTSD, moral distress, certainly frustration and confusion, loneliness, and there were lots and lots of behaviors when people were isolated. And of course, before COVID, people had more liberty and were not isolated. So during the COVID pandemic, the limits imposed upon them about their choices and decision making and other liberties due to their cognitive limitations and substance abuse effects were something we had to take into consideration. So, do we take away the person's substance? Do we impose abstinence? And we absolutely, again, with the donated CAMH leftover stock of nicotine, we were able to support these individuals. So we looked at the principles to guide decision making, so respect for persons, equity, proportionality, and reciprocity. So we wanted to make sure we minimized the harms. So we need to consider that any harms that may result from the decisions that we're making, we have to consider how we can prevent or limit those harms. And we also needed to be fair. That means paying attention to the factors that disadvantage some people, and that may be, poverty, racial or ethnic backgrounds, gender identity, etc. But mental illness, substance use, we needed to have fair and equitable treatment. And stigma can affect those decisions. And throughout the pandemic, there were some considerations to the people who were the smokers. There was a view that that people would be able to make some informed decisions, and not everybody was. Not everybody was able to make informed decisions around what they wanted to do for smoking. So we needed to help them. We needed to have some transparency, and we also had to take into consideration a duty to protect. To protect the individual as well as the people in the long-term care home. So what approach do we take with older adults? So we first and foremost have to assist with acute nicotine withdrawal, whether or not they plan to quit. Again, whether or not they plan to quit. And we had to look at some behavioral interventions and creativity, and those are critical. We needed to use those throughout. And there is a consideration that some older adults will require some medication given their level of dependence. And we know that nicotine replacement is the best studied medication and potentially works better in the older age group. And again, in the setting in a long-term care setting, medications are administered. So there's no chance that people are forgetting or missing or, putting two patches on or leaving the patches, leaving, patches all over their bodies, which we have seen in the community, people forget. The other is to starting the patch based on how much they're smoking. So getting an idea or a gestalt of how nicotine dependent they are. And sometimes, and that did happen quite often in long-term care homes, that we had to use a short-acting NRT as a PRN on top of the patch. So again, based on patient preference, their dental status, their cognition, and the spray, as I mentioned earlier, was particularly helpful with cognitively impaired. So in the community setting, we had some people who were ready to transition to long-term care. This is a gentleman who's a long-term smoker, smokes about 20 cigarettes a day. He has a diagnosis of Alzheimer's and is smoking very safely in his garage. And instead of having all of the cigarettes at once, we counseled the wife to limit the cigarettes and just put 2 cigarettes in the package at a time. And but what's happened is that the wife needs to put her husband in respite while she's away, and so we looked at using the nicotine patch. So what we did was he was given the patch, and then in his pocket he had the package of cigarettes, but it was empty. And what people would do is he would say, well, I'm out of cigarettes. And the wife would say to him, well, you've already had your cigarettes and that's all you have for today. And he was okay with that. He bought that, and he was fine. And he had a 21 milligram patch. The other thing that the wife did was made sure that she always had candy in his pockets, because as we know, candy will also fix a craving for sugar. Candy or sugar will fix a craving for nicotine. And again, reminders that he'd already smoked. And eventually he stopped smoking, and the patch was discontinued, and he was able to go into long-term care without any worries. And it's important to plan for those transition. One thing that we need to point out is in the older age group, it doesn't mean that they need a lower dose. In fact, they may need more because of the degree of nicotine dependence. Sometimes people who are deeply forgetful, if they have Alzheimer's, they may smoke and not remember that they've had the cigarette, and they light up and they're actually smoking more than they did when they were well. So we know that nicotine replacement can be used even if there's no long-term goal to quit. And you can use it in those who are not ready or able to quit. And we can use it to reduce smoking and reduce smoking-related agitation behaviors. And that's by stabilizing those serum nicotine levels. So what did we do? What we offered? So we had all donated nicotine replacement from CAMH. It was unused nicotine from the clinic. So we had the nicotine spray. We had the patch. I got some inhalers from Toronto Public Health, and we got some lozenges from the Ottawa Heart Health Institute. So I was desperately going around with my hand out, and everybody knows me. If I put my hand out to ask for something, I'm going to take your arm. So we got donated. We got the donated NRT from mostly from CAMH, 90% from CAMH, and it was very, very. It was very welcome and used in the long-term care homes. So the important thing is that we had a number of people in long-term care and in the community that have comorbid medical conditions. So these are some medications that you want to monitor after the quit. And the one thing that I noticed in some of the residents that had schizophrenia, that they really stabilized nicely when on the patch, or if they had a regular dose of the spray. And again, because their serum nicotine levels were steady, it meant that their medications were, became stabilized. And I had one gentleman who said to me that he just felt so much better being on the patch and having access to the spray PRN, because he said, in the middle of the month, I run out of money, and there's always some month left. And so he would normally have to go out and borrow cigarettes from people, sort of stem or pick up cigarette butts. And so now he didn't have to do that. So he really was quite happy to continue using the patch, and then eventually cut down and stop. So you want to watch out for psychotropics, caffeine, hypoglycemic agents, and warfarin, because there are some unpredictable effects on the INR. So this is a really great chart. I'm not going to read it all to you, but again, remember, it's not the nicotine that's harmful. It's the burned tobacco. So these slides will be available to you, and the links, I'm going to provide the links to Natalie to put at the end of the slide deck. And this is a list of all the drug interactions with tobacco smoke that you might want to have taken into consideration. So it's a great handout. So think about this, is particularly with older adults. You've got somebody who's been smoking for 40 years, and they may have started at age 13, and they're looking at quitting at 53, and they haven't been successful, or they're looking at 63 or 73, so they might have 40 to 60 years worth of smoking. So if they smoke 25 cigarettes a day, that's over 40 years, that's 365,000 cigarettes. And that is 4,380,000 hand-to-mouth repetitions. So you're asking somebody, in their 60s, 70s, and 80s to stop that, to stop having, that level of nicotine in their body, but also that repetition of hand to mouth repetitions. And if you think about it, you're asking somebody who has possible, or has a diagnosis of Alzheimer's, so there may be cognitive impairment, and you're asking them to change, but they may not remember what you're asking them to change from. So we want to make sure that there's a steady level of nicotine administered. And the other thing is that the person who has a diagnosis of Alzheimer's or other types of dementia, they may not know what the patch is for. So if you put it on their in an area where they can reach it, then they may take it off. So you want to put it in an area where the patch can't be disturbed. And if there's a report or evidence that the person is having some nightmares, some distressing dreams, or if there's some irritation on the skin, then you would want to take it off at nighttime. I think in the Teach chat, if those of you who are regular Teach on the Teach listserv, there's been lots of back and forth about what to do when there's irritation on the sites where the patch is, using some creams on it, some steroidal creams. And also take into consideration the use of combination therapy, so the lozenges or the spray for breakthrough cravings. And the nice thing in a setting such as long-term care or a supportive housing, nurses can apply the medication and they can also give a PRN when there's some behaviors present. So if it's obvious Mr. C is coming to the nursing station and he's saying, I want my cigarettes now, you need to give them to me now, and you can do something to give him comfort right away by giving him the spray. So this is a gentleman, he's 70 to 80 years old, male, living in long-term care. He has mild cognitive impairment. He smokes between 25 and 40 cigarettes per day. But how do we know that he smokes between 25 and 40 cigarettes per day? He gets 5 cigarettes at a time from the nursing station because he's so persistent. He's always at them. And sometimes he can trick them. And you can say, well, that nurse didn't give me my 5 cigarettes. You can ask her, and he was very convincing. So he was able to sometimes get 10 cigarettes in an hour, and he would go out and he would just smoke them constantly. And so now what's happened, he's COVID positive and he's got responsive behaviors. He's leaving the floor to smoke all the time, and he's touching the elevator buttons, and he's holding onto the railings, and he's going out and he's smoking, and he's leaving those cigarette butts behind, and the other residents with cognitive impairment are coming and picking up his butts. And we wondered why the infection rates were going up in this home. So he was refusing to isolate, and he was wanting to leave the facility. So, how do you provide a sort of ethical and supportive environment for this gentleman? How do you protect the other people in the home that are at risk of getting COVID from him, and meeting his needs? And what happened is that we actually we did an OTN e-visit with him, and he chose what type of nicotine replacement he wanted. And I said, now run to the pharmacy, don't walk, and get him what we have recommended. And he put the patch on, and he didn't really like it. It did cause him some nightmares. So we said, well, do you want to try this other thing, the spray? The spray was free. CAMH had given us all these donations of the nicotine spray. So he was able to do that himself, and he was able to self-regulate, and it completely changed the way that he interacted with the staff. His serum nicotine levels were stabilized. He didn't go out. He stayed in for the duration of the illness, and he recovered so nicely, and he's continued to stay on it. So we never ever asked anybody to stop permanently. We said to people, this is a temporary situation right now. You have to be in isolation. We need to keep you safe, and we need to keep the other people safe. When things change and you're able to go outside, and you can choose to smoke again if you like. And this gentleman actually, that was March of 2020, and he still is no longer smoking. So we learned an awful lot. There's a few silver linings from long-term care. So when you're using the nicotine spray, you want to take into consideration the person's cognition. Can they understand and appreciate why they're taking it? Can they understand and appreciate how to self-regulate it? That is not something that you take, to taste it. It's going to replace the cigarette. So you don't want to give it to residents who can't self-regulate. You need to administer it at the nursing station, and because the benefits of those sprays are immediate, and they can decrease the behaviors associated with that purposeful exit seeking to smoke. So people who are used to going out to have a cigarette outside, this will help with that exit seeking. And if the spray is chosen as an option, you can set up a schedule with the resident and have regular sprays. For instance, how many times a day would you like to have? How many times a day do you usually have a cigarette? Is it as soon as you get up, as soon as your feet hit the ground, you go outside for a cigarette? Then we have to make sure that that person has access to a spray right away, first thing in the morning. So they may choose to have one before breakfast and after breakfast, or they may choose something they can wait until after breakfast and have one after breakfast, after lunch, after dinner, and then one before they go to bed. So again, speak with your resident and ask them, when they would like to have their nicotine spray. We don't want to have them in a situation where they're going into withdrawal from nicotine, and then they borrow a cigarette from somebody, or they sneak one in the bathroom, or or in their room where they have a resident next to them that's on oxygen. So we want to avoid any other risks associated with the smoking. So again, we need to be fair and transparent, and I felt that we were very fair and transparent during the outbreak. We respected that the substance use that they were using, that was their choice, no matter what they used, if it was cannabis, if it was alcohol, if it was nicotine. And we informed them that it was negotiable, what was negotiable and what was not negotiable. So if there is somebody who is at risk for fire, if they're not a safe smoker, then that's a whole different kettle of fish. We needed to make sure that everybody is safe, and everybody needs to be protected for the greater good. So we have Mr. C. He's a long-term smoker. He's smoked 60 to 65 cigarettes per day. Family would bring in bags of cigarettes and from the reserve, and they would give him the bag, and he would just smoke it continuously all day, and he could even go through 200 cigarettes in a couple of days, 2 to 3 days. He has a history of schizophrenia, very, very poor impulse control. He did stop smoking during the pandemic using the nicotine spray, but there, again, another lesson learned was that this is somebody who didn't have very good impulse control, and he continued to spray, and he would use up 1 canister of the spray over the course of 2 days. So that's 150 sprays in those canisters. So it was quite a lot. So we switched him to the nicotine patch and then gave him PRN spray. And he continued to ask at the nursing station for spray and cigarettes. And recently he started to borrow cigarettes from others, and he was calling the family to bring cigarettes. And he stopped, he started to smoke on top of what he was getting, and he fell out of his wheelchair, and he didn't even have the insight to even get himself up. He kept the cigarette in his mouth with his face planted on the cement, and he continued to smoke. So he had no insight whatsoever. And so in that situation, what would you do? How do you support that individual? So we wanted to make sure that he had was safe, and was he considered a risk for harm for fires and or burning himself? And the answer was absolutely yes. Can he understand and appreciate the consequences of his risky smoking? No. There was one day that there was an ice cream truck outside, and they handed him an ice cream, but he wanted to have a cigarette, and he couldn't even uh, deal with having a cigarette, the ice cream in his hand. So he threw the cigarette, he threw the ice cream out so he could have a cigarette. And when he was finished his cigarette, he went back and asked for another ice cream. So he really was not in control anymore. So are they capable of making the changes? So using a smoking apron, we offered him a smoking apron and he said no. And was smoking supervision, is that reasonable? In most long-term care homes, it's not reasonable to have somebody go outside and supervise everybody smoking. So in that particular home was not a reasonable option. So the option was for a complete discontinuation of smoking for him because cognitively he had changed so dramatically and he was no longer safe to smoke. So we increased the nicotine patch to 28 milligrams daily with no cigarettes available. And what happened, again, his serum nicotine levels stabilized, his mood improved, and he was now able to recognize that he was feeling better, and he was very grateful for the addition of the patch, and there was no further need for him to be using a PRN of like a short acting. So we know that with the inhaler, it's a more expensive option. You want to make sure that the person can self-regulate. And the other is that one nicotine cartridge with 20 minutes of continuous inhalation equals 4 cigarettes. So if you have somebody who has no self-control, they may sit there and smoke that for 20 minutes and they've got 4 cigarettes, the equivalent of 4 cigarettes. So can they keep that? So that's something to take into consideration. Can they self-regulate? So can they keep the inhaler safe away from other residents? And can they keep the little plastic inhaler piece? Can they keep that safe and not lose it? Sorry. So one of the things that we did with some of the residents is we placed. Sorry. Sorry about that. Okay, so one of the things that we did with when people had inhalers, again because of the risk that they might lose them, is we took the a piece of string and put it around wrapped the string around the inhaler, but we put Scotch tape on it. We didn't use duct tape or anything like that, but something that was easily released so that if it got caught on something that it would just pop off. So that was something that was really helpful. And we also, with some individuals, if they were able to self-regulate, we gave them one cartridge at a time and said, try and keep a routine. So this one should last you, a few hours, 4 hours or so. And if they were a heavy smoker, we said, and they got a routine, they were allowed to have up to 5 and some 6 cartridges per day for a 1 pack a day smoker. And then also there were some times when the consideration was using a combination of patch and inhaler with only 1 pod per day, and that worked out very well. So again, we wanted to minimize the harm. So what are some of the non-pharmacotherapeutic options. The one thing that was really, really interesting, we had one home in particular that because there were so many people ill with COVID and they were locked down for such a long time, people were not getting out, but they decided at some point that people needed to get outside, and they sort of adopted the model that CAMH did when you had the SARS outbreak and people went out for fresh air breaks. So instead of saying to people, you can go out for a cigarette, you can go for a smoke break, now everybody's going to be offered opportunity to go out for a fresh air break. So it was called a fresh air break. People could go outside and you could, at a social distance, socialize with people, but you couldn't smoke. And that was done primarily because there just wasn't the resources, enough staff to bring people out 5 and 6 times a day to have a cigarette. So we had people had fresh air breaks, not smoking breaks. The other is that people who were really low-level smokers, and if they smoked 4 or 5 cigarettes a day, we offered sugar. So we offered lollipops. And remember, I mentioned the number of hand to mouth repetitions with somebody who smokes a pack a day for a year. A large number of hand to mouth motions. So people really, really like the lollipop. So it just happened to be around Halloween. So we said, go out and buy a couple of bags of lollipops. And so one person in particular was very successfully using the lollipop. And it was kind of nice for her because she had some social interaction as well. She could yell down the hall, she and say, nurse, can you bring me a lollipop? So, and they did a little bit of a pro-attention plan. They would offer it to her. So lollipop, that sugar really fixed her craving for nicotine. The other was adult coloring books. Again, keeping people's hands busy. So having, if somebody's in isolation, having these things on their table that they could, do some adult coloring. The other was offering juice or pop or water. We had one gentleman who was always sort of, they termed it as exit seeking, but he would automatically go to the nursing station because he wanted to go downstairs for a cigarette. And as soon as they saw him coming to the nursing station, he was offered a small glass of root beer. That was his favorite drink. And as soon as he had the root beer, he would swallow it down and he would go back to his room. He didn't ever ask to go out after that. So a pro-attention plan, again, checking on people and seeing how they are. Can we get you anything? And providing lots and lots of activities while in isolation. The other important thing is the smoking apron, and keeping the hair pulled back. We've had a number, I think since 2020, there have been about 6 tobacco-related fires with residents in the Toronto Central Lynn that I have heard about. There may be some others that I haven't, but people who have set their hair on fire, who have set their clothing on fire while smoking because the ashes dropped or the hair was flying in the wind. So we always say, if the person is going to smoke, make sure that their hair is pulled back, or if they've got a beard. I mean, that was another situation. Somebody had a beard and that caught on fire. So keeping the beards trimmed or shaven if there's a concern about them burning themselves. So in terms of the nicotine gum and the lozenges, so the nicotine gum, really, that's not a great choice for most people, especially for older adults. They may have dental issues. They may have dentures. They may have crowns or lots of fillings, and so it sticks to it. And the other thing is the whole issue of if the person is able to remember to chew, and then park it. And not many people are able to do that if there's cognitive issues. So, so if they cannot remember to chew, and park it, then they're going to chew it all at once and then end up feeling nauseous from the amount of nicotine they ingest. So, and the other piece around the nicotine gum is, do they understand and appreciate that they cannot share that with other people? This is nicotine. It's not gum. It's not dentine or Excel or whatever. It's not something to share. And that's something you need to really screen for. Make sure if the person knows that these gums are different than regular gum. And then with the lozenges, we again, same situation with the nicotine gum as with the lozenges. Can the person remember not to chew those lozenges? So if they don't have that impulse control, they don't understand why you're getting it, they may think it's a mint, they just pop it in their mouth and they crunch it and chew it, and then they've taken the lozenge all at once. So can they understand those in um, can they understand that they have to, put it in their cheek, suck it, and sort of park it for a little while and let it dissolve slowly? So again, it boils down to how to self-regulate. So all of these sort of considerations for older adults, these are, again, frail people in long-term care. And I see somebody's putting in the chat there about choking. Yes, that was also another piece, is a choking hazard for somebody using the lozenges. And I did have somebody who he used the lozenges, and price was a consideration. So what they did was they purchased the no-name brand ones, and they were able to break them into quarters. And he was somebody who knew and didn't have any choking problems, but knew to park it and so on. And what they did was they broke the highest dose lozenge into quarters, and he could keep those in his pocket, and he knew not to share them, and he was able to sort of self-regulate. But if he had to wait even 5 minutes, if somebody said to him, you're come to the nursing station when you want a lozenge, if he had to wait for 5 minutes, then he would go downstairs and he would bum a cigarette, or he would pick up cigarettes off the ground and smoke butts. So it's important, again, for people not to have to wait, because they may not have that ability to. Their craving for nicotine may be so strong. So we're at 12:46, so we've got a few minutes for questions. And so I'll just open up the chat box, I guess, and see, Natalie, if there's particular...
Yeah, there's been lots of great questions. Amanda asked, she said, you mentioned NRT can be used when a resident is not ready to quit. Can the resident safely be on the patch and continue to smoke?
That's a tough one, but we, with the guidance of the Nicotine Dependence Clinic, there are some people that really don't want to give up. And so we have, under guidance from the physicians at the Nicotine Dependence Clinic, said, okay, well, how many cigarettes a day? If you still have the patch on, how many reasonably would you want to smoke? And we landed on a low number of 3 to 4 cigarettes a day, and that was okay. And that person stayed with that regime, and there was no problem. There was someone who was very seriously burned, and we didn't want that person to smoke at all. And so they agreed to take the patch, but to have a couple of smoking breaks, and those had to be supervised breaks. So having a cigarette while they're on the patch, it's the burned tobacco. It's not it's not the nicotine that's harmful to them. So while we don't want them to smoke, it's not it's their right to have the occasional cigarette, and their head's not going to explode. They're not going to have a heart attack and stroke. The heart attack and stroke is caused from the smoking itself, the burned tobacco itself. So, and all the toxins in it. So I see there's one in there about the client has no money for NRT. That's a really interesting one, because I always say to family members, there's no money for an NRT, but there's money for cigarettes. So, but there, we are working, and CAMH has been really wonderful. Natalie, maybe if this is a time to talk about what CAMH is going to be working on for long-term care homes.
Yeah, so we are actually currently, our STOP program in the nicotine dependence service is collaborating with long-term care to co-develop a program that will work within long-term care homes. So we're working with a small number of homes for an initial launch and hope to expand from there. So I believe if you have any questions about that program, you can reach out to Carolyn Peters on our team, on the STOP team. So I can put her email there. Hopefully, Carolyn, if you're here, that's okay with you. I will put it in the chat there. Yeah, so I know there's a couple other questions as well. Villa said, are there any creative activities / hands-on programs available in the community to keep them engaged?
Well, if anyone goes to a day program in the community, as somebody who has who's cognitively impaired, there are day programs, and of course they can't smoke when they're in day programs, so it's important to have NRT available to them. So there is something said to be to being busy and having some meaningful activity, and that's where the activities that I described to you before, the using the adult coloring books. We even had, during the pandemic, we offered DVDs, little video players for residents so they could watch movies. The other interesting one for people who are quite cognitively impaired, we used robotic cats and dogs, and they could pet them, and that kept their hands busy. But still, you need to take into consideration if this person is a heavy smoker, you're still going to need some nicotine replacement.
Right.
So.
Awesome. There was also a question from Caroline, I believe. She said, I've heard nicotine itself is carcinogenic, but I also still hear nicotine isn't the problem. Is that because of relative risk, or?
Well, the nicotine itself is not, it's the, what is it, what's it called? The polycarbons. Just hang on a second here. It's the PAH, so the polycyclic aromatic hydrocarbons that are found in tobacco that induce liver enzymes to be responsible for those metabolism, and those drug. Sorry. So, sorry about that.
No problem.
Okay. So again, I'm going to turn my speaker off, okay?
In the meantime, I will just go to the next slide. So, Marilyn's email is there, so if we happen to run out of time for any of your questions, you can feel free to reach out to her.
Okay, so again, there's over 2,000 chemicals in a cigarette, and all of those toxins that are in the cigarette are what's harmful, and that's that burned tobacco. So the nicotine itself is not harmful. It's certainly addictive. There's no question about it. It's very addictive, but it's more addictive even than heroin, they say. So. But so we don't worry about the nicotine being the harmful piece. It's the burned tobacco.
Right.
And also in this population, the risk for fires and so on. So Carol, it says, I've read that 21 milligram patch is equivalent to 10 cigarettes. So if an individual is used to smoking more, it likely won't be harmful. So I'm not sure do you mean, so a 21 milligram patch is used for someone who smokes, up to 15 to 20 cigarettes per day, if I'm not mistaken, or so it's about a pack a day smoker, and again, for some of the folks that we had that wanted to have the occasional cigarette, it wasn't a big deal. It was more the physicians were worried about if there were going to be any ill effects from it, and we know that the OMA now has recommendations around use of NRT, that it's much safer than originally thought. So. And what else do we have here? Villa Colombo. I think we talked about that, hands-on programs. If you have people who are like to keep their hands busy, knitting, any tactile activities, again, that keep that person's hands busy can be very, very helpful. And the other thing is, I always say to people, again, who are cognitively intact, offering them drinks, a cup of tea or a glass of water. If you drink a glass of water, it might take, a minute or two to drink it. By the time you've had that, then usually that craving is sort of settled down a bit. So. And again, we will be looking at the CAMH is going to be supporting our long-term care homes with a new provincial program. So thank you so much to CAMH. We're forever in your debt. We really appreciate that. It's so needed. So if you're interested in being part of the pilot, we're going to roll out just a few homes. So be in touch with Carolyn Peters. And do that fairly quickly because we want to get moving on it. Because we are right now, I don't know if Peter's in the audience there listening, we're running on zero nicotine replacement at this point. I was going to say on fumes, but there's not even fumes to run on. So.
Yeah, it looks like Carolyn's actually away for a few weeks. So send any questions to stop.study@kmh.ca. And someone on the STOP team will be sure to answer you there.
Yeah.
Go ahead.
I just see that there's the one about the no money for nicotine replacement. The other thing is to take into consideration that if people in long-term care have a public guardian and trustee, and the public guardian and trustee, if you present if the person is in need of nicotine replacement, then they can authorize payment for it. And that's an option. Again, just make sure that you've got a consultation note to indicate that this is something that would be helpful for the person, and again explain that we'll be switching over from cigarettes to nicotine patch, and you're going to have to finish off the cigarettes first because the person may not be able to afford both, and give them notice and say, well, you've got enough cigarettes left over for the rest of the month. When those cigarettes run out, we're going to start you on the patch. Because you're not safe anymore. We've got to bring somebody outside with you to make sure that you're not dropping your cigarettes and so on. So we'll be starting the patch in 6 weeks or so or whatever.
Right.
Again, in a very caring and compassionate way. Because, as I said, I've seen and heard of so many fires in this population.
Right.
So.
Well, it looks like we are getting to the end of our time now. But I do know, I think there might have been a couple outstanding questions. Is it okay, Marilyn, if they reach out to you at your email there, if they have any questions?
Yeah, sure. I see there's someone from the Yukon that's interested. Absolutely. Feel free to reach out. My information is there.
Awesome. Well, thank you so much, Marilyn, for such a great presentation today. Lots of very hands-on suggestions, and it is very clear that everyone found it very helpful. So thank you so much. Before we go, if you do need to head out now, that's okay. I'm just going to go through some reminders and housekeeping items before we end off. So if just a reminder that the evaluation and post-learning assessment will be emailed to you by the end of tomorrow, and you'll have 1 week to complete that if you're interested in receiving a letter of completion for this teacher educational rounds. Along with that, you'll also be receiving a copy of the slides as well as a copy of the recording if you would like to review or share with any colleagues. We also just want to take the time to let you know about our next Teach Educational Rounds, which will be happening on Thursday, not our usual Wednesday slot. So on Thursday, December 15th at 12 to 1 on smoking cessation in a hybrid care model. So we hope to see you there. And if you missed a portion of today's webinar or want to view it again or are interested in seeing a previous Teach webinar, an archive list can be found on our website. So feel free to check that out. For now, thank you all so much for joining today and engaging with us. And thank you again, Marilyn. We hope you all have a great rest of your day. Thanks, everyone.
Thanks, everybody.
Thank you. Bye.